So my name's Jo McPeake, and I am the Professor of Nursing at the Healthcare Improvement Studies Institute at the University of Cambridge and Cambridge University Hospitals. So where did it all start for me in terms of nursing? Well, a lot of people think that I'm from Glasgow, but I'm not actually from Glasgow. I moved to Glasgow when I was 17 to start my nurse training. And my first placement was in an area of Glasgow called the Redwood Flats. And the Redwood Flats were at the very north of the city, and they were built in the 1960s. And there were 8 of these huge flats that were really seen as the pinnacle of living in Glasgow. They each had 28 floors. And on a good day, you could see out as far as the Isle of Arran. The view was so spectacular. However, these flats unfortunately quickly fell into disrepairs. As lifts broke down, people left the flats less and less. Social isolation became common. Drug and alcohol use became problematic, and it became a challenging environment to live in. And this was my first placement in Glasgow in 2000. Like many student nurses, I went out with the health visitor as a raring to go student nurse. My first placement was in a mothers and babies group, which was predominantly made up of younger mums. And I remember walking into that room, and the overwhelming feeling I had was one of love. These young mums, who some of them were the same age as me, all they wanted was the absolute best for their kids and their babies. However, the pace of their lives would be absolutely dictated by the environment in which they lived. And really, this was my first step, and this is where my interest in health inclusion and social inequalities and the social determinants of health really came from. Following my placement in in Springburn, I moved to Glasgow Royal Infirmary to undertake some placements. And for the eagle-eyed comic book fans, you will recognise this as Gotham City. And this was a few years back where the Batman film was filmed, and this is Glasgow Royal Infirmary in the backdrop. So, when I started in Glasgow Royal Infirmary, and my first placement was there in 2001, the average life expectancy of a man in that catchment area was around 57. There was a large proportion of people living with complex comorbidity and mental health problems, and drug and alcohol use was the highest in the UK. It was a real problem, this hospital based in the northeast of Glasgow. However, I have to say the Glasgow Royal Infirmary patients quickly stole my heart. Their absolute ridiculous sense of humour, their approach to incredible and real life adversity and how they managed it meant that this hospital became my professional home for many years to come. And as well as adversity and social deprivation and all the challenges that comes with, Glasgow Royal Infirmary was the home of huge innovation. And here are 2 innovators from Glasgow Royal Infirmary. This was John McIntyre. John set up one of the world's first radiology departments, while Joseph Lister here was a pioneer of antiseptic surgery. He developed antiseptic methods when he was a surgeon in the infirmary and was a professor of surgery at Glasgow University. And his work with the use of carbolic acid to prevent infection significantly reduced post-op mortality and really is the foundation of modern surgery. Glasgow Royal Infirmary was also a huge innovator in nursing, and this is Rebecca Strong. And Rebecca took up a post as matron of nursing in Glasgow Royal Infirmary at the behest of Florence Nightingale. And Rebecca Strong set up a brand new programme of nurse education alongside her medical colleagues. most notably Sir William McPeake. And what she did was she released nurses from clinical practice for several weeks, and nurses would come in to a teaching area and they would learn theory. They would learn the lessons that underpin the clinical practice. They would then go back into clinical practice and put that theory into practice and really ensure that they were bringing together both that excellence in education and excellence in clinical practice. And they did this as a multidisciplinary team, working in close collaboration with Sir William McPeake. And this is really the foundation of modern nurse training now. This is how we still do modern nurse training, where students will go into the university and they will learn their theory, they'll learn research and all the education that underpins clinical practice, and then go into clinical practice and really put that learning to the best approach for patient care. So undoubtedly Sir William McPeake was such a huge advocate for nursing, professionalism of nursing, education of nursing. However, he did have some interesting views. This was a quote that I found in the archives of the Royal College, and he had quite interesting views of nursing. And he thought that one can scarcely expect a man to be a nurse, as his instincts and training do not suit him for it. A woman possesses such a magnificent compass of susceptibilities, is so full of human sympathies and soft compassions. If her life is not to be a barren wilderness, she requires opportunities to enable these to expand. I think Sir William and I would have had a lively dinner discussion. So I did most of my nurse training in Glasgow Royal Infirmary, and as I was coming towards the end of my training, I spent time in intensive care, and I had a 6 or 8 week block in Ward 25 of Glasgow Royal Infirmary. And I have to admit, when I started in intensive care, I really struggled with it. I had a mixture of fear and apprehension about the environment and the nursing care delivered. It was so different from working in a surgical ward or a medical ward. But over the weeks, I slowly became to really love the type of nursing that was delivered there. You got to know everything about the patient, and you cared for them in an incredibly holistic and indeed privileged way. And I soon came to love it. During my time as a student nurse in intensive care, and the thing that probably sticks out most in my mind was the Stop-Line Plastics disaster. I was in intensive care while this happened. So Stop-Line Plastics disaster was a major incident that happened in Glasgow about 20 years ago. And Stop-Line Plastics were a major employer in the north of the city in an area called Maryhill. And there was an explosion in the factory, and the explosion was thought to be related to a corroded gas pipe that ran underneath the building, and it leaked and it caused the explosion. On the day, there was 9 fatalities. The building, as you can see in this picture, completely collapsed. And as you can imagine, many more people ended up in hospital that day. And there's a lot that sticks out when I think back to the Stop-Line Plastics incident. It taught me about exceptional multidisciplinary care, it taught me about exceptional communication and team working. However, the thing that it taught me most was about family care, and the importance of family and people's social circumstances. The people that get our patients better are their families, their social networks. And the clinical team have to do absolutely everything possible to care for this important group if we're truly to improve outcomes for our patients. And that's the learning that constantly sticks in my mind. So following Stop-Line and my placement in intensive care, I really had to make a decision about where I wanted to work. And most student nurses would tend to go and do a surgical rotation or a medical rotation in a hospital where you try out different wards where you work as a staff nurse. But I knew I wanted to work in intensive care after my placement there. That was quite unusual, though. It was unusual for student nurses to go straight into a critical care first post. However, I was given permission to apply for a job in Glasgow Royal Infirmary, and I was lucky enough to be successful at interviewing. So I went straight into intensive care following training, and I started as a trained nurse in Glasgow Royal Infirmary in 2004. So I worked in Glasgow Royal Infirmary for several years. I loved it. I loved doing all my competencies. I loved doing all the kind of, very technical roles that you learn to do in intensive care. And I undertook a master's degree and worked closely with the Scottish Patient Safety Programme. And that really sparked my interest in how we improve the care of our patients and the power of research to do that. And I recognised that I wanted to do more research because I could help more than just that patient in front of me. However, I wasn't quite ready to leave the bed space yet. I knew I had still lots to learn as a nurse, a few years into my post. And I knew I also had a lot to give by being a nurse at the bed space. I was lucky enough to have two medics that I worked closely with in intensive care, Professor Tara Kassim and Professor John Kinsella. And they were clinical academics. There wasn't a huge number of nursing clinical academics at that time, but they were medical clinical academics. And I'm not even sure the term clinical academics was a thing then, but looking back, they definitely were. And John and Tara were so welcoming. They were absolutely seen the value of having robust nursing research and having nurses as part of the multidisciplinary research team. And when I look back and think about what I learned from Tara and John, there's no such thing as nursing research or physio research or pharmacy research. Research is research is research. What we need to aim for as a multidisciplinary team is high quality research that aims to improve patient care. It has to be done to an exceptionally high standard. So I was lucky enough to work with Tara and John over a number of years, and I undertook a PhD. It was funded through the Florence Nightingale Foundation in Tenerife, Scotland. And all the way through my PhD, I continued to work as a bedside nurse in intensive care. And unsurprisingly, I undertook a project related to health inclusion and social outcomes, and it was around alcohol-related admissions to critical care. And I've got to say, this project was driven out of curiosity. In Glasgow Royal Infirmary, we would see young men and young women, late 20s, early 30s, presenting with end-stage liver disease because of alcohol. And many of them would actually make it out of intensive care. And I was curious about what happened to them. Did they get the support they needed? Did they go back to the same social circumstances which had driven their admission in the first place? And that's really, and I've got to say, from that moment on, this is how all of my projects and all my research are kind of created. It's through that clinical curiosity. And what we found in this project is that about a third of admissions to critical care were related to alcohol. People who did have alcohol dependency were twice as likely to die in ICU, and mortality longer term was drastic. It's 200% higher at 6 months than people without alcohol dependency. But I undertook this as a mixed method study and followed patients up. And what I realised is we could make a difference. We could do something about this with good anticipatory care, with good recovery care following intensive care. So what do we do about this? Well, following my PhD, I was really lucky enough to be successful in an application for a Winston Churchill Memorial Trust travelling fellowship. And I got to travel to the States and work in different areas, including Boston and the IHI. It was fantastic. And it really was transformational on how I was thinking about how we support people after intensive care. But what's been most transformational for me is the relationships that I've maintained. And this picture in the top corner here, this was just last year, and this is people that I met during my travelling fellowship and who I've maintained relationships with and who I still work with. So it really was a transformational in my thinking, but also in the relationships that I've had and really been privileged to have over the last 10 years or so. So When I came back postdoctorally, I was aware that I wanted to do something to support people after intensive care. But at the same time, we were seeing randomized controlled trials from the UK really demonstrating limited impact of recovery interventions. We've seen nurse-led follow-up clinics, we've seen kind of in-hospital physical-based rehab not showing much success. So we went back to the drawing board and we created the UK's first patient and family advisory council. And this was a direct output of my fellowship. I had went to Beth Israel in Boston and seen one of these groups in action. And we worked with a very diverse group over the course of a year to co-create an intervention to support patients and, most importantly, their caregivers following intensive care. And we came up with an integrated model of follow-up. And it was inclusive of the entire multidisciplinary team and also other patients. So that a core kind of facet of the Inspire programme was peer support. And we got a small grant from the Health Foundation to test this intervention out in 48 people to start with in a single centre. We started with one patient and scaled this complex intervention up. And we were then lucky enough to have another larger programme award from the Health Foundation to then scale this up to multiple sites in Scotland and test both the implementation and the effectiveness of this. And I think it's at this point I really have to recognise the kind of trust and risk that the Health Foundation really took on this project and the faith they showed in us. This was a complex intervention. We brought in social care professionals, we brought in peer support. We did things that at that point weren't the norm, and the Health Foundation had absolute faith in us. And they've been hugely influential in the work that we've been able to do with this programme. And I was really humbled that in 2016, the team were awarded the Innovation into Practice Award for the Inspire programme. And this is definitely the Spice Girls moment of my career. But when I think back, obviously there was huge learning and developing the Inspire programme and the different facets of it and scaling it up and running a big multi-centre study. But there was lots of other learning that will stay with me. The first is what research brings to team. And these are some of the teams that we had. And in these teams, we have, people from carer centres out in the community. We have pharmacists, psychologists, nurses, medics, and bringing teams together to really appreciate people's different skills brought such joy to people's work that transcended the Inspire programme. It went back into clinical practice. And having a team that kind of, where no single discipline was in charge, it was about everybody bringing their specialised skills to the betterment of patient care. And again, that brought capacity within people. It released such such potential in people and brought people joy. And that was a huge part of learning. And this multidisciplinary wasn't just within the clinical practice. We made sure that we continued this multidisciplinary approach right across the entire programme. And this included publications. And, in these publications, we have OTs, we have physios, we have pharmacists, we have community providers. And again, really getting people involved in that research not only benefited patient care, but really benefited the professional that was involved. And I put up a picture here of Martin Shaw, who was our clinical scientist involved in this, and they are often the unsung heroes. And when I speak about multidisciplinary care, I don't just mean the providers of the care. And Martin is a brilliant example of that. He was there from the very start with those first 48 patients and setting up this programme. And, when we think about multidisciplinary care, it's not just the direct providers, it's those clinical scientists who absolutely make everything possible. Another thing that I'm really proud of this programme is that patients and family members were involved across the entire journey. They designed the programme, they tested the interventions, they delivered peer support, they disseminated learning. This is two patients on the front page of the Lancet Respiratory who came back and became volunteers. And I think that really demonstrates the value that patients, the value of patients in this programme and how much a part they really played. And I remember speaking to the two ladies on the front cover and saying, do you want to be on the front page of Lancet Respiratory? And they said, what is Lancet Respiratory? And I highlighted that this was like Vogue for medical staff, of which they absolutely bought into. The other thing that I'm incredibly proud of is that we had a huge impact on our patients and families and the critical care community. But this programme also transcended the critical care community and, had an impact on how we could deliver health in this integrated way to really improve outcomes for our patients. During this time, and following my Winston Churchill Memorial Trust Fellowship, I was also deeply privileged to have many international connections, and this wouldn't have been possible without Professor Jackie Washner from Johns Hopkins, who was previously in Michigan. He absolutely sees the value of multidisciplinary engagement in research, but also has this unique ability to link people up with like-minded people internationally. And really, Jack has been such a foundation in the international connections that I've made. And he's really pushed me to think differently, and he's really pushed me in academic endeavours over the last few years. And one of the things that he linked me in with was the Cairn study, and I was really proud and privileged to be one of the clinical leads and one of the research leads for the Cairn study. And this was a study that was undertaken in 17 sites and 3 continents, which was a huge undertaking, as you can imagine. But what we did with the Cairn study was really think differently. It was about moving away from being problem-focused, and it was, well, we know the challenges that this patient group have, but what can we do about it? What are the things that are going to make a difference for this patient group? It was really that positive deviance approach, and how can we make a difference post-intensive care? I've also been able to continue with my interest in the social determinants of health and health inclusion with Jack and other members of the international community, and I've learned so much about financial determinants of health and actually how they vary across international sites, but actually how the social determinants of health undoubtedly have an influence in our patient care. I was, following my work with Cairn and other studies, I was really humbled to be awarded the International Early Career Achievement Award from the American Thoracic Society. And obviously I was humbled that my colleagues put me forward for this award, and I was humbled to be awarded it. I was the first non-medic to be awarded this, and I was the first non-medic to be awarded any critical care assembly award from the American Thoracic Society. Again, something that I'm deeply humbled around. And clearly I'm very proud of that, but it's really what came next that I'm most proud of. In 2022, Emma Ridley, a dietitian from Australia, Monash, was awarded the prize. And in 2023, Bronwyn Conley, a physiotherapist from Queen's in Belfast, was awarded the prize. I hope I had a small part to play in people moving forward and going for that award. So, as I was coming out of the Inspire programme and the learning from the Inspire programme, I still had a bit of a bug to kind of fight, and that was that we were seeing many patients, despite the Inspire intervention, being readmitted to hospital. And this was a huge issue for both patients and their family members, and the anxiety that caused and the ongoing frailty that caused. So I was lucky enough to be awarded this Institute fellowship to specifically understand why people were readmitted to hospital and potentially what we could do at different transitions of care to try and prevent hospital readmissions. And I just had, the most phenomenal experience with the Healthcare Improvement Studies Institute in my fellowship, and obviously working in partnership with Homerton College, really that foundation of equality, diversity, and inclusivity. I felt incredibly privileged to be part of that fellowship. So I started my fellowship in December 2019, and March 2020, the world changed, and we've seen the COVID pandemic really hit the UK. And I made the decision to go back to clinical practice full-time as a nurse in intensive care during that time. And I'm not really sure what this picture shows, other than I am very short. For those who don't know me, I am very short, as is demonstrated in this picture. And it was genuinely a huge privilege to be part of the clinical team on and off for 2 years, delivering care to patients admitted to hospital with COVID. It's a time that I'll never forget, but one that we were able to be there for patients and their caregivers. I was also a part of more health inclusion research, as you can imagine, during the COVID pandemic, and I was really privileged to be involved in some national work around outcomes following critical illness. And again, with that real lens of health inclusion and social inequalities. And what we demonstrated was that people who were admitted to intensive care from areas of deprivation had worse outcomes, and also that hospitals in areas of deprivation were hit harder, and actually it was going to take them longer to recover following the COVID pandemic. We also undertook work around people's social circumstances, and again, we found that people who were from areas of deprivation really struggled to re-engage following discharge from the hospital. And, this is some data around, for example, employment after critical illness. For those who worked in critical care during the pandemic, I think the thing that will always stick with me was the lack of family visitation and the impact that had for patients and their family members. And in some cases, staff really became the primary caregivers for some patients, which, again, I don't want to underestimate what a huge privilege that was. But this really, again, drove research in this area for me. And I was really privileged to lead an international study around family member experience of the pandemic across the UK, France, and Spain, really learning about what it meant to family members to not be there. And I think we sometimes underestimate the impact that this lack of family visitation had on staff as well. And again, as part of this international study, we had the privilege of working with staff to try and understand the impact that it had on them. And it was the impact of not really knowing your patient and understanding the influence that family members have on how we can deliver exceptional care. During the pandemic, I was some of my work was covered internationally, including this kind of press coverage elsewhere. I really tried to get my Glaswegian colleagues to, I really liked this title that had been given, but unfortunately my Glaswegian colleagues weren't too keen on this new title for me, and it didn't quite take off, but perhaps it might take off in Cambridge. So what next for me now that here in Cambridge? What are my research aims? Well, the first is the work that I will continue to do with building capacity for NMAP research and multidisciplinary research, which I'm sure you can gather is such a driver for everything I do. And with this fantastic team, we aim to create a roadmap to building successful and sustainable clinical academic careers for NMAPs. Like everything, the focus will be on scientific excellence along with that underpinning focus on equality, diversity, and inclusivity. I'm also particularly interested in focusing on social frailty. Over the last 15 years or so, appropriately, the critical care community has been focused on physical frailty and the outcomes that can cause in our patients, both coming in and going out of intensive care. I'm interested in social frailty and what that might do, and the components and what drives social frailty. And social frailty is having lost or at risk of losing social and general resources, activities, or abilities that are important to fulfilling one or more basic social needs across the lifespan. And I think this is crucial in intensive care, and I think there's several drivers to that. So what do I think? Well, I think one of the first drivers is treatment burden. So treatment burden, when you think about it, you might think, what's that got to social outcomes? But stick with me. So treatment burden is the workload of healthcare and its effect on patient functioning. So how much work it takes for that patient and social unit to maintain health. And we know that there is huge treatment burden following critical illness. We know there's deterioration in chronic conditions. We know that there's new disability following critical illness. We know we're really rubbish at managing comorbidities, both during critical illness and across transitions of care. And we know that we cause new and worsening mental health problems for survivors of critical illness. And all of this can drive treatment burden. And when we see treatment burden in patients, we know that there's increased healthcare use. We know people are more likely to end up back in the hospital. We know that there's poor treatment adherence. We know there's increased mortality. And we know that there's poor health-related quality of life. And all of that drives reduced social participation, reduced social engagement, and actually all of that can have a tremendous impact on patients and their outcomes. Another driver of social frailty is financial insecurity. And we know there's several drivers of financial insecurity following critical illness. We know people experience reduced employment, medical insurance can become an issue in certain healthcare systems. We know there's new caregiving roles and caregiver burden. And we know people really struggle to access welfare and social support that they need to maintain health. And financial instability is really important to our health. This is data that was published in JAMA a couple of years ago, and it was in the heart failure population. And what it showed is when there's perceived economic burden, 1 year outcomes are worse, both in terms of mortality and health status. And this is across the socioeconomic status. This isn't when we think of areas of deprivation or people who live in areas of deprivation. This is all people. Financial instability and financial insecurity not only drive social frailty, but can be a real predictor of healthcare outcomes. And we can do something about it. We showed in the Inspire programme that if you provide welfare and community support, patients take it. Patients will use it if you make sure it's accessible to them. And interestingly, caregivers also ask for support. Huge issue and can really drive social frailty. Another component of social frailty that I think is hugely important and drives social frailty and critical illness is social isolation. And this is a large meta-analysis that was done several years ago, but what it shows is that social isolation, which we know is really common in survivors, has a bigger influence on our health than things like obesity and physical inactivity, and has a likely similar kind of influence on our health as alcohol and smoking. It's a huge influence on our health. We know it's common and we know it's likely to drive social frailty. And undoubtedly, I think you've heard my passion for family members and informal carers. We know that they really struggle both during the critical illness and following critical illness. And we have to do more to support them because they're a key player and they're a key mediator in how people do after intensive care. So I think the next thing we have to think about is social frailty. We know it's just as important as physical frailty. We know it can lead to reduction in health-related quality of life, like physical frailty. We know it can increase mortality. We know it can increase healthcare utilisation. And interestingly, new data from the older adult population would suggest that it could actually drive new cognitive impairment. So for me, this is a concept I really want to focus on in the coming years here in Cambridge. Thank you so much for listening, and please do contact me if any of these concepts are of interest to you. I would love to hear from you. Thank you.